This is Dr. Ruby. Welcome to the lecture for Module 9, Functional Anatomy of the Shoulder. I wanted to go over some of the muscles for you and discuss their relationships, so you can use this in addition to the reading that I've provided for this module to better understand the shoulder girdle. One of the largest muscles in the body is the latissimus dorsi. Its origin is in the thoracic area, the iliac crest, and also in the thoracolumbar fascia and the ribs of 9 to 12. It then inserts in the inferior angle of the scapula and the intertubercular groove of the humerus. The isolated functions of the latissimus dorsi are internal rotation, adduction, and extension of the shoulder. When used bilaterally, it creates spinal extension, and it can also create an anterior pelvic tilt of the pelvis. The integrated function of the latissimus dorsi is that it accelerates internal rotation and adduction of the arm. It provides stability to the lumbopelvic hip complex. If you look at relationships of the latissimus dorsi, you find that when it is short, it can create an anterior pelvic tilt. Also, when it is short, it can create glenohumeral internal rotation and adduction, or what we call the upper cross syndrome. Weakness of the latissimus dorsi causes a synergistic dominance of the subscapularis and the anterior deltoid. A dysfunction of the latissimus dorsi can create arthrokinetic inhibition at the iliosacral joint, the thoracic spine, or the scapulothoracic joint. The anterior pelvic tilt created by a short psoas, weak gluteals, and weak deep abdominals can cause the latissimus dorsi to become short, which can then result in glenohumeral impingement. The serratus anterior originates on ribs 4 to 12 and then inserts on the medial border of the scapula. The isolated function of the serratus anterior is scapular protraction. The integrated function is that it decelerates dynamic scapular retraction. It works synergistically with the upper and lower trapezius to provide optimal scapular mobility and stability during shoulder elevation. It is a member of the scapular force couple. It provides dynamic stabilization to the scapulothoracic joint. The serratus anterior, when weak, can alter the normal scapulohumeral rhythm. This leads to synergistic dominance by the upper trapezius and the levator scapula, and it may result in glenohumeral impingement and cervical spine dysfunction. The rhomboids. The origin of the rhomboids is at the spinous processes of C7 to T5. The insertion is at the medial border of the scapula. The isolated function of the rhomboids is scapular retraction and downward scapular rotation. The integrated function is that it decelerates scapular protraction and upward rotation. It provides stability for the rotator cuff to work efficiently. Weakness of the rhomboids can decrease scapular stability, which increases the stress to the rotator cuff musculature. Thoracic spine arthrokinetic deficits can create arthrokinematic inhibition of the rhomboids. The levator scapula. The origin of the levator scapula is the upper 3 or 4 cervical vertebrae on their transverse processes. The insertion is on the medial superior angle of the scapula. The isolated function of the levator scapula is lateral flexion and rotation of the cervical spine. The integrated function is elevation of the scapula and downward rotation of the scapula. When the levator scapula becomes short, it inhibits upward rotation of the scapula. When the levator scapula becomes dominant, it inhibits the upper trapezius through synergistic inhibition. The lower trapezius. The origin is at the spinous processes of T6 to T12. The insertion is at the spine of the scapula. The isolated function of the lower trapezius is scapular depression. In an integrated function, it works synergistically with the upper trapezius and the serratus anterior to abduct the scapula during elevation. This helps to maintain the appropriate length-tension relationship to the rotator cuff. Weakness of the lower trapezius allows synergistic dominance by the upper trapezius and the levator scapula, creating internal impingement. Weakness of the lower trapezius also allows synergistic dominance by the pectoralis minor, which can lead to shoulder pathology. Any kind of thoracic facet dysfunction can create arthrokinetic inhibition, which decreases the force production capabilities of the trapezius. The middle trapezius originates at the spinous processes of T1 to T5, and then it inserts on the medial margin of the acromion and superior aspect of the spine of the scapula. The isolated function of the middle trapezius is scapular retraction. Its integrated functions are that it works synergistically with the upper and lower trapezius and the serratus anterior as part of the force couple system of the scapula. Weakness of the middle trapezius can cause postural compensations that lead to upper cross syndrome. The middle trapezius can be inhibited from short pectorals, which decrease scapular stabilization. Any kind of thoracic facet dysfunction can create arthrokinetic inhibition of the middle trapezius. When the middle trapezius is short, the levator scapula alters the length-tension relationship of the trapezius. The upper trapezius originates on the external occipital protuberance and the medial third of the superior nuchal line. It also originates on the ligamentum flavum and the spinous processes of C7. The insertion of the upper trapezius is on the lateral third of the clavicle and the acromion process. The isolated function of the upper trapezius is cervical extension and lateral flexion and contralateral rotation. The integrated function is that it works synergistically with the lower trapezius and the serratus anterior in the force couple to abduct and upwardly rotate the scapula during elevation. The upper trapezius provides dynamic stabilization of the cervical spine. Overactivity of the upper trapezius may create cervical facet dysfunction. It may also create reciprocal inhibition of the lower trapezius, leading to tissue overload to the rotator cuff that will ultimately lead to compressive pathology of the rotator cuff. Underactivity of the upper trapezius can decrease the force couple relationships and cause synergistic dominance of the levator scapula, which alters the normal arthrokinematics of the cervical spine and the scapula. This will affect all muscles that attach to the cervical spine and the scapula. The pectoralis major originates on the clavicular portion in the anterior surface of the clavicle. It also begins at the sternal portion on the anterior surface of the sternum, the cartilage of the ribs of 1 to 7, and the external oblique. The insertion of the pec major is at the crest of the greater tubercle of the humerus. The isolated function of the pec major is shoulder flexion, shoulder internal rotation, and shoulder horizontal adduction. Integrated function of the pec major includes deceleration of shoulder extension, external rotation, and horizontal abduction. The sternoclavicular joint may have dysfunction, and this may create arthrokinetic inhibition of the pectorals. Overactivity of the pectorals may create reciprocal inhibition to the rhomboids and the middle and lower trapezius. Overactivity of the pectoralis major may also create rib dysfunctions in ribs 1 to 7. Additionally, overactivity may create relative humeral internal rotation, which predisposes the biceps and the supraspinatus to impingement. The pec minor originates at ribs 3 to 5 and inserts on the coracoid process of the scapula. The isolated functions of pec minor are that it protracts the scapula. Its integrated functions are that it works synergistically with the pec major. Overactivity of the pec minor may create reciprocal inhibition of the rhomboids and the middle and lower trapezius. Underactivity of the rhomboids and the middle trapezius in turn will allow scapular protraction and tightness of the pectoralis minor. Overactivity of the pec minor may create a rib dysfunction, affecting respiration and hyperfacilitation of accessory respiratory muscles. The origin of the deltoid is on the anterior lateral third of the clavicle. The middle deltoid is on the lateral and superior acromion, and the posterior deltoid is on the spine of the scapula. The deltoid then inserts on the deltoid tuberosity. The isolated functions include the anterior deltoid, shoulder flexion and internal rotation, the middle deltoid, shoulder abduction, and the posterior deltoid, shoulder extension and external rotation. The integrated functions are that the anterior deltoid works synergistically with the pectorals during functional activities. The middle deltoid works as a force couple with the supraspinatus during abduction, and the posterior deltoid assists in deceleration of the shoulder following throwing or hitting. The deltoid has several relationships. The anterior and posterior deltoid work as neutralizers during abduction. If the anterior deltoid is overactive, it lengthens the posterior deltoid, altering the normal force couple relationship. This alters glenohumeral motion and may lead to impingement. A peripheral nerve entrapment of the axillary nerve decreases the neural drive to the deltoid. This decreases the isolated and integrated function of the muscle and leads to synergistic dominance and altered arthrokinematics. This can be caused by tightness in the latissimus dorsi, the teres major, or the triceps. The sternoclavicular or acromioclavicular joint may have dysfunction that can alter the function of the deltoid. An overactive levator scapula or upper trapezius can alter the position of the scapula, which then alters the length-tension relationship of the deltoid. The origin of the supraspinatus is the supraspinous fossa. The insertion is at the superior facet of the greater tubercle of the humerus. The isolated function of the supraspinatus is abduction of the arm. The integrated function is that it works synergistically with the other rotator cuff muscles to dynamically stabilize the humeral head in the glenoid fossa. It initiates abduction and dynamic caudal glide, while the deltoid acts as the prime mover during shoulder abduction. Overactivity or tightness in the levator scapula and or the pec minor alters the position of the scapula, which in turn alters the length-tension relationship of the rotator cuff. Any peripheral nerve entrapment of the suprascapular nerve can lead to decreased neural drive and decreased function of the supraspinatus. The infraspinatus originates on the infraspinous fossa. Its insertion is in the middle facet of the greater tubercle of the humerus. The isolated function of the infraspinatus is shoulder external rotation. Its integrated function is that it works synergistically with the other rotator cuff musculature to dynamically stabilize the humeral head in the glenoid fossa during functional movements. The infraspinatus works synergistically to produce dynamic caudal glide of the humeral head in the glenoid fossa during elevation. It works as an integrated functional unit with the capsule ligaments and other cuff musculature to enhance stability and proprioception during functional movements. Any overactivity of the infraspinatus and the levator scapula and or pectoralis minor alters the position of the scapula and will lengthen the rhomboids, the middle and lower trapezius. This alters the normal scapulohumeral rhythm, which affects the normal length tension and force couple relationships of the rotator cuff musculature. Overactivity and tightness of the latissimus dorsi can lead to tissue overload of the rotator cuff. Weakness and underactivity of the teres minor or the posterior deltoid can cause synergistic dominance of the infraspinatus. Teres minor originates on the lateral border of the scapula. It inserts on the greater tubercle of the humerus. The isolated functions of the teres minor are shoulder external rotation. The integrated function is that it works synergistically to produce a dynamic caudal glide of the humeral head in the glenoid fossa during elevation to prevent impingement. It works synergistically with the other rotator cuff musculature to dynamically stabilize the humeral head in the glenoid fossa during dynamic activity. It works as a ligamentous muscular protective reflex which enhances proprioception during dynamic functional activity. Underactivity in the serratus anterior or lower trapezius decreases scapulothoracic stability and alters the length-tension relationship of the rotator cuff. Overactivity and short length of the levator scapula or pec minor affects the position of the scapula, which affects the position of the glenoid fossa, which affects the function of the rotator cuff. The subscapularis originates in the subscapular fossa. It inserts then in the lesser tubercle of the humerus and on the glenohumeral shoulder capsule. The isolated function of the subscapularis is shoulder internal rotation. The integrated function is that it works synergistically with the other rotator cuff musculature to stabilize the humeral head in the glenoid fossa during functional activities. The subscapularis decelerates shoulder external rotation during dynamic activities. The subscapularis has several relationships. Poor posture and/or pattern overload creates an anterior migration of the humeral head and lengthens the posterior rotator cuff, increasing anterior and superior humeral head migration with a resultant impingement. Teres major originates in the inferior angle of the scapula and inserts in the lesser tubercle of the humerus. The isolated function of teres major is shoulder internal rotation, adduction, and extension. The integrated function is that it works synergistically with the latissimus dorsi, anterior deltoid, pec major, and subscapularis in acceleration of internal rotation. It assists in deceleration of shoulder rotation, abduction, and flexion. The teres major has several relationships. Poor posture leads to excessive shortening. Pattern overload leads to muscle imbalances. Repetitive adduction and internal rotation movements lead to overactivity and decreased length. This affects the normal force-couple relationships of the rotator cuff musculature. These are the references for this lecture.